on our sheet. I think a posterior direction. Posterior. So if I'm going to glide posteriorly, okay, I'm gliding it down this way. So if I'm going to push this and it's going to push down, okay, so this is going down, what motions am I going to improve? So take your shoulder if you can feel it. Most of us can feel, like if we come back this way, can you feel that humerus roll anterior? Can you kind of feel it pop into your hand there? Okay, now if we go into intra-rotation, can you kind of feel it kind of pull back the other way, posterior? Does that make sense?
Mm-hmm.
Okay, so you can kind of feel it a little bit. You know, most of our shoulders glide appropriately. Then if we want to extend or we want to flex, can you feel which way it moves that way? So which one would I be improving, intra-rotation and flexion or extension?
Extension.
And flexion, yes. Okay, can you feel it glide a little posterior with flexion? Feel it glide a little anterior with extension? Yeah?
No.
Okay.
Oh, that makes sense. Okay.
I'm not following. Can you just explain it again?
I was just having you feel it, But in general, it's easier to either look at the shape of the joint and understand it that way than just memorize it. But what we want to know is with a posterior glide, my humerus is going to glide posteriorly. So because the roll and glide are not in opposite direction, I'm going to have a improvement in flexion and intra-rotation motion, okay? So I can feel it on myself. I don't even have to think about which way the roll and glide are, because if I put my hand here on my humeral head, as I move into flexion, I can kind of feel that slip back this way. You can usually feel it pop into your hand as you come into extension. You really have to start at neutral, and then you got to move, and you can feel it come forward there. If you can't feel it, just get a shoulder joint out and watch it, or learn the shape of it. Okay. Okay. So posterior glide is to improve what two motions?
Internal rotation.
Wonderful. So with this, once again, I want them close enough to the edge that I can glide posteriorly, okay? So it's going to be posterior, straight toward the ground. Once again, scapula stabilized by the table. I'm going to mobilize humerus, okay? I'm going to glide straight posterior. I want to be on the humeral head, and I want to get my body right over that. So I've got straight elbow and gliding straight down, okay? If I got a bent elbow and I'm working like this, I don't get quite as much. So I want to be here, a little bit of traction, just separation, and pushing straight toward the ground. Posterior glide. Okay? Anterior usually is done on their stomach, so if you don't mind me, go ahead and flip on over. I can pull up. It's a lot easier to push down. Okay? So if I've got him here on his stomach, and I'm thinking anatomically, an anterior glide is going to be this way toward the floor as well. Make sense? Scoot your butt over here, Dad. You can just rest your forehead straight down. This pillow can go kind of like right there, or you can use that face rest on the table. So once again, I kind of prop them up here. This position, I do have to stabilize, scapula kind of will be stabilized here, just, by their pressure of the gravity acting down too a little bit, okay? Usually I want to bring them up a little bit here, just so I've got like a clear joint surface gliding here. So I'm kind of at, an even plane here. I don't want them like drop down here because I'm going to be jamming the joint. Does that make sense to everybody? So either I want to prop, a few towels underneath here, or I want to support them. Some people, if they're tall enough, they can do this and support them here, and it's a lot easier. You can get a little footstool or something like that. People do a little rolling, thing in the clinic. Okay? But that, I've seen a lot of people do. Just put them up here, and then to apply the glide. Because I'm short, I don't do those things. So recognize that what is the position our shoulders most likely to dislocate? Anterior, right?
Mm-hmm.
So if you have a patient with a really hypermobile joint, please don't dislocate them, okay? They will move a lot more this way, so just be careful. If you have a hypermobile shoulder, just kind of when your partner's doing this, just say, hey, be nice to me, be gentle, okay? We don't want anybody's shoulders dislocating tonight, okay? Clear? Clear, okay. Usually patients don't require this as much, but you might have to do this, okay? So just be aware that it exists. So if we want to improve anterior motion, anterior glide, okay? We're going to have external rotation and extension. We just kind of figured that out by process of elimination. We just did the last one, okay? So we improve the external rotation and extension. So here, same thing, right on the humeral head. And I am just doing a little bit of traction, and I'm going straight down toward the ground, anterior glide. Okay?
So you are not holding scapula, you are stabilizing the
Scapula, yeah, kind of like gravity body weight, you know. I mean, it's not body weight now, but gravity kind of pushing down, yeah.
Are you doing small oscillations or?
Right now, I'm just kind of oscillating. I'm going like about a 2, you know, maybe a little bit into a 3. I'm just showing you guys the position that you want to be in. Then you will grade it as appropriately as your patient requires.
And how much time do you want to generally stay in a position like that when
You
you're
know what? I mean,
oscillating?
that's a good question. For pain relief, I don't know what Tim usually does. I mean, if I feel like it's, you know, kind of like they feel pretty relaxed with it, it's just kind of starting to glide. A lot of times, if you have a patient that has a restricted joint, even if you're just doing a little bit of a mobilization, like grade 1 or grade 2, I usually do about like maybe 20 to 30 oscillations, and you can start to feel like, you know, it just starts to seem like, you know, the coordination, the movement gets a little bit better. I just kind of find like around that one is where I kind of find like things are starting to kind of like, you know, you're not really getting joint mobility, but it seems like things are just kind of like, you know, loosening a little bit in there. They might just start to relax, you get a little bit of that neural, you know, feedback or something in there. Generally a joint mobilization, you can do it as long as you want. You can do it for 45, 50 seconds. I mean, if you feel it's really stuck and it needs it, you know, you might do this for 30 seconds. You might take a break, you know, if they're looking like they're kind of like, oh my gosh, you know. Sometimes patients tolerate this really well. Sometimes it feels really good because that's what their shoulder needs, is that glide to be restored. A lot of times people will be like, oh, that feels so good, you know. So, you know, I've done it for 45 seconds, you know. Sometimes I give them a break, I come back and do it again. So as long as you feel like they really need that and they're getting some mobility gained, you know, you might stay there and do, if that's what they really need, that's the treatment you want to use for them. Any other feedback you want to give on that, Tim?
Here's what we have in the lecture, is that the rapid isolations are called, you know, small quick movements. Grades 2 and 3, which are a little larger amplitude, 2 to 3 second hold time, 1 to 2 minutes. That's what's in the lecture. I will tell you, like Sarah said, if I'm trying to increase range of motion, I'm doing a grade 3, I'm gonna get a good mobilization and stay there a little longer. I'll hold a mobilization for 5, 10, 15 seconds and kind of get a sustained stretch of that capsule. And that tends to work better for me. This is what's in the textbook, but generally I'll hold a 2 and a 3 a little longer than that clinically. Does that make sense? Especially at 3, we're trying to increase range of motion. The 3 is where we're going to use a lot of that. And I'll get in a good position, feel that translate to the end of the range, and I'll stay there and sit. As long as the patient can tolerate it, I may start with those oscillations and then get in those grade 3s and stay there for a while. And usually they can tolerate there for quite a while. 4s are a little more intense, so we don't hold them as long.
Or you can kind of go back and forth between a 3 and a 4, you know.
Yep.
Okay, you guys ready to practice that?
Sure.
Yeah.
Okay, cool. We're going to be
What are
coming
we
around and
practicing?
help you out.
What are we practicing?
We're going to practice joint traction, long axis traction. We're going to practice glenohumeral joint distraction, 90 degrees. Practice an inferior glide to improve abduction, posterior glide to improve internal rotation and flexion, and an anterior glide to improve external rotation and extension. Okay? Anterior, posterior, inferior, and distraction and long axis traction. Okay? Go.
Wednesday.